Good afternoon, good morning everyone. My name is Sume Ndumbe-Eyoh and I'm with the National Collaborative Center for Determinants of Health. Today is October the 17th, 2017, and we're on for the webinar Raising the Social Determinants of Health and Health Equity. Please note that today's webinar is being recorded and will be available on our website, www.nccdh.ca, for viewing a few days after the webinar. Please note that you can use the chat box at any time during the course of today's presentation to ask any questions, share resources, and also engage with the presenters and other participants. To get us started, we'd like to know who's on the line, so your name, where you're calling in from, your organization, and any racism-related work you're doing. You can also share your specific interest in today's conversation. Oh, great. I see a number of people introducing themselves there. Thank you very much. Glad to have you all on the call with us today. As I mentioned, we're now on slide number 3. My name is Sume Ndumbe-Eyoh. I work with the NCCDH as a knowledge translation specialist. I'm also joined on the line by my colleague, Danielle McDonald, who's a research assistant with the center. It is an immense pleasure to have our advisor on tap today, Dr. Ingrid Waldron, who is an associate professor at the Faculty of Health at Dalhousie University. Ingrid is also the director of the Environmental Noxiousness, Racial Inequities, and Community Health Project, also known as ENRICH. She is a sociologist whose scholarship focuses on the sociology of health and illness, and which includes the health effects of environmental racism. Again, a great pleasure to have you joining us here today. We've done some work with Ingrid in the past, most notably a case study which we did with her on her work with the ENRICH project, and that is available on our website, and we can also share a link with participants after the call today. So we'd like to know who else is on the line, who's joining us. So let's see who we have with us. So Danielle, if you can pop up. Oh, great. So great to see people from Ontario, BC, Alberta, Saskatoon, Manitoba, Northwest Territories. A few people join us from the States. Great. Thank you all for joining in today. Great to have you all. So as I mentioned, today's webinar is being brought to you by the National Collaborative Center for Determinants of Health, also known as the NCCDH. The NCCDH is located in Antigonish, Nova Scotia. Our host university is St. Francis Xavier University. The NCCDH is located in Mi'kmahi, which is the Mi'kmaq name for the province of Nova Scotia. Mi'kmahi is the ancestral territory of the Mi'kmaq people. I honor this land today in recognition of Indigenous resistance and as a call to us all to remember our responsibilities as treaty peoples. This responsibility calls on us to pay attention to ongoing colonial processes and to all work with undoing the gross inequities which exist today. Our particular focus at the NCCDH is on the everyday living conditions which affect health and well-being, and so that's really our focus, the focus of our conversation today. So to that end, we work to translate and share evidence, on interrelated determinants of health and to advance health equity by working with public health practitioners, researchers, and decision makers from across Canada. The NCCDH is part of a network of 6 NCCs funded by the Public Health Agency of Canada. Each NCC has a shared mandate to support public health programs and policies by increasing the awareness of new and existing knowledge in topics related to our specific mandates. The NCCs focus on Aboriginal health, environmental health, infectious diseases, methods and tools, as well as healthy public policy. And we're all located in a different part of the country and have a pan-Canadian mandate. So our conversation today specifically, and I'm on slide 8, is to talk about systemic racism, so racism as a systemic force, and we'll do so by describing core concepts related to racism, as well as to introduce racism as a standalone determinant of health and well-being, and as such as a key priority for intervention by public health actors across the country. So to get us started, I'd like to know, those of you on the line, are you addressing racism as part of your work? And if you are, do you have any strategies, policies, Is it something which you're starting to think about? Is this not on your radar at all? Great. So it's really encouraging to see that about 40% of people already have strategies, policies, or activities. Close to that number is people are also starting to think about it. Again, these are very encouraging numbers for those people who are not yet thinking about it or who don't know. We're really hoping that today's conversation will be a small step to push your organizations in that direction. Thank you, Danielle. So as we know, health equity is concerned about all people, individuals, groups, and communities having fair chance and opportunities to reach their full potential. So we know that health inequities exist because of conditions in society which are unfair. The inequities we see are systematic, so they show up in very clear and predictable patterns. And I think most importantly, they are avoidable. So that means we can do something about them. One of the ways in which we see health inequities show up is along racial lines. So for today's conversation, we'd like you to think about how does understanding racism and colonialism, how does that help us all become more impactful actors within the public health system or in whatever other systems you find yourself working and living in. As part of our work on racism, and we're on slide 11, earlier this summer we released a document as part of our Let's Talk series. The document is called Let's Talk Racism and Health Equity. It's available on our website in English et aussi en français. And we're hearing from a lot of people that it's a really, partly because it's a really useful document to start the conversation within your organizations. For people who have been doing this work for a very long time, and many of you are on the call today, it can be another tool in your bag of tricks, tips and tricks to just further support that conversation. If you're using the resource, we'll love to hear from you about how you're using it and how that's going in your work. So what do we mean by race in the first place? On the screen right now on slide number 12 is a quote from Ta-Nehisi Coates from his book Between the World and Me. And he is a US-based writer. He says, "But race is the child of racism, not the father. And the process of naming the people has never been a matter of genealogy or physiognomy, so much as one of hierarchy. Difference in hue and hair is old, but the belief in the preeminence of hue and hair, the notion that these factors can correctly organize a society and that they signify deeper attributes, which are indelible, this is the new idea at the heart of these people who have been brought up hopelessly, tragically, deceitfully to believe that they are white." I think in this quote, he's really speaking powerfully to the idea of race as a social invention. So in a sense, we start categorizing people based on races, which are imaginary, fictitious, as a way to justify a system of racial oppression. So that's what he means when he says race is a child of racism, not the father. And I find really this idea centers race as a social and political construction. So we talk about races, or races exist because they serve a particular purpose. And the purpose really is to create a system which systematically advantages white people and oppresses people of color and indigenous peoples. And so I think this really speaks to the centrality of white supremacy as what holds racism together. And a lot of times when we talk about white supremacy, I think we tend to think about some extremist groups across Europe and North America. We're seeing that these sentiments are not so extreme, but they're really a core way in which most European and North American societies, and really the world, has been and continues to be organized. We're seeing a profound rise in white nationalism. I'm thinking about the very brand new election of a new chancellor in Austria who really ran on a white nationalist platform and got elected. So things that I think speak to the importance of naming and addressing white supremacy as the problem. So if we talk about racism, privilege, those are symptoms of a system then which creates opportunities for others and actively denies other people those opportunities. So on slide 13, I thought it was important to talk about some of the core pillars of white supremacy. On the diagram on that screen, we see 3 pillars: anti-Indigenous racism, anti-Black racism, and Orientalism. I think together these work in tandem to then maintain the system of white supremacy. I'm going to spend the next couple of slides going into these three ideas a little bit more deeply. So as I mentioned, white supremacy is a system which assumes that the practices of whiteness are the right ways of organizing human life. And what this means is that we then define certain communities as white, and the practices of those communities, the practices which are generated on a daily basis, are then embedded in our everyday practices, in our everyday policies and systems, and then become used as the measuring rod for everyone in society. This is really based on a belief in the inherent superiority of people who are defined as white. It comes with profound systemic and institutional power to then go ahead and enforce that belief. It is, as a system, white supremacy benefits all white people, regardless of socioeconomic status, gender, sexual orientation, and other things like that. And benefits in that system then get doled out based on how close one is to whiteness. As a system, white supremacy then assigns value and grants opportunities and privileges based on race. I think it's important to note that there is absolutely no aspect of our society which is spared this. So in all our systems, we see this up in our politics, in our history, in our culture, in economics, and other social systems and institutions. So what racism does is that it makes whiteness the preferred way of being. And so groups who are defined as white consistently get more advantages, and groups which are defined as not white consistently become disadvantaged. I think it's important to note that whiteness is not fixed. It's something which is constantly changing. If we recall what I said earlier as race being a social invention, it's not static, it's not fixed. So how we define who is white and who is not white is something which has changed over time and continues to change. And we do that in ways which continue to privilege others and disadvantage others. So I didn't go to high school in Canada, but for those of you who did, if you think about history, think about what you learned as Canadian history. Whose stories were told? Who are the heroes in those stories? How were the Indigenous peoples of this land represented in those stories? Were they active in Canadian history? I think the answer would be quite obvious, which histories were told and which histories were buried. I think we're starting to see a slow shift in that, and we need to ensure that those things are then changed at a systematic level. So when we talk about histories, we talk about a more balanced and arguably a real history of this country. So as we mentioned, so related to white supremacy, so the way white supremacy then shows up is through structural racism. And here we're talking about inequities or inequalities which are rooted in how society functions on a systemic and a systematic level. And so structural racism include members of racialized groups from participation in major institutions. And I want to stress the significant participation, because a lot of the times you hear stuff like, oh, but let's think about the Obama effect, right? So Obama apparently transcended race, which he didn't. So unless you have people of color and Indigenous people participating in major ways in our social and political institutions, racism is still in place. And we are at a point in society where that is not yet the case. So oftentimes when we talk about racism, especially in popular culture and in the media, I think we tend to focus on very individualized and interpersonal forms of racism. So things like, come and call me a swear word or slurred or the N-word and things like that. And I think those things are important, but what they do is they really obscure the fact that the reason that is possible and the reason that has such a detrimental impact is because racism operates at a structural level. So each incident of individual or interpersonal racism we see actually emerges from structural racism. So I think that's a really important thing for us to think about, because oftentimes when issues of racism are raised in workplaces, right, people then tend to get defensive and say, well, but I didn't do anything racist, so racism definitely cannot be operating. We're at a point in time where a lot of racist policies are no longer explicit. Some of them are still are. Think about the Indian Act, which really has very clear and explicit racist undertones. But a lot of the policies which have racist outcomes are not explicitly racist. So it's really important to focus on the outcomes, the racialized and unequal outcomes we see, and not necessarily the racist intent which may be there, because sometimes we can see racialized outcomes without any clear actor, because the actor in this case really is the system. So our work then as public health actors is to understand how the system works to then create and reproduce racialized and unequal outcomes. So specifically, if you think about institutional racism, we can think about very specific institutional policies and practices which exist to create differential outcome. Let's think about the employment as an example. There's something called Canadian experience. I think Canadian experience, as it's used, tends to be a way in which racism is maintained within our employment systems. And a lot of times we just take that as a matter of fact, and we don't really question what we mean by that or what that's designed to do. So when we start to understand what structural racism sounds like, what institutional racism looks like, then we can start to pinpoint entry points for action. So a few examples I'd just like to throw out there for consideration. In the education system, for example, we know that college professors are more likely to respond to emails or correspondence which they believe come from a white male. I'm pretty sure this is not unique to the higher education level. It starts to build up from our very point in the educational system. And so through this, we can see how that kind of implicit bias then builds up into the profound differential outcomes we see for racialized and Indigenous students in our educational systems. Similarly, in the health system, we know that health professionals have a differential reaction and treatment for people of color than they do for white patients. An example which I think is really profound is the belief, so studies have found that white people believe that black people feel less pain. I'll let that sink in. White people believe that black people feel less pain. So if we agree that race is not about biology, then that obviously has no basis, makes no sense. But if you hold that belief, then it means that the empathy towards black people, towards people of color is reduced over time. And it starts to help you understand why we can justify higher sentences in the criminal justice system for children of color, for Indigenous children. It also starts to help you understand how even when patients are diagnosed with similar conditions, similar health conditions, the treatments tend to be different. So if you believe that black people feel less pain than white people do, you're less likely to prescribe them the appropriate and the recommended medication. So this is really not about the individual health professional's intent to discriminate. It's something which is which has been built in. But I strongly believe that we can work towards uncovering these in our everyday actions. As I mentioned in that earlier slide, one of the ways in which white supremacy functions and continues to function is in the Canadian context and in lands which continue to be occupied is through settler colonialism. So anti-Indigenous racism and settler colonialism are function hand in hand. By settler colonialism, I am referring to the permanent occupation of a territory. So let's think about Canada. Canada is being permanently occupied by people who are non-Indigenous, and the goal there is the ultimate removal of Indigenous peoples from that land, to build a community which is separate from what existed before. So again, told to obscure and to wipe out the existence of Indigenous peoples who were here and who continue to live on this land. And understanding and unpacking settler colonialism, I think, is a really critical, has to be a really critical focus as part of our work. We know that the profound social and health inequities which exist for Indigenous communities is really rooted in settler colonialism, and in the dispossessions of Indigenous lands and the lack of self-governance for many Indigenous communities. So on slide number 17, one of the other pillars of white supremacy is anti-black racism. And this is racism which targets black people or people of African descent. And one of the core ways in which Blackness is defined is like almost like the antithesis of whiteness, right? So I think some examples of this, if you think about the kind of language we use, our everyday language speaks very profoundly to this, light and darkness. And so racism which targets Black people, we see it in histories of slavery, in colonization, in ongoing policies in our health, education, criminal justice system, which unfairly targets Black people. I was at a session a few months ago, and someone who works in the settlement sector, so deals with immigration and migrants and policy issues, shared a profound example about how our immigration policies, our refugee claim system has racism built into this. So if you come from an African country, it takes about 64 months for refugee claims to be processed compared to about 12 months if you're coming from other parts of the world. The last pillar of of white supremacy is Orientalism. And so this is the idea of defining people who are non-white as the other, as exotic, as different. And not just different, but different and inferior. I think one of the ways in which we're seeing it play out in very real ways is a lot of the anti-immigrant sentiments which we're experiencing. There's been a profound rise in Islamophobia, which is, technically fear towards Muslim people, but really I think about as systemic discrimination towards people perceived as Muslim. The recent attack in Tibet a few months ago, the bombing of the mosque, is a profound example of that. So all these three things, anti-Indigenous racism, Orientalism, anti-Black racism, all really work hand in hand to sustain white supremacy. And I think the reason this is a really important bit is understanding how these things are always at play helps us then, if we're working on racism, it helps us understand how ideas of who's inferior, who is not, are developed and enacted in real life. So I know that people online who may be focusing specifically on, say, anti-Black racism or anti-Indigenous racism, and in your work I'll encourage you to think about what lessons are you learning from that which could be adapted to other issues. So, like, how does that help you understand racism as a system, even as we focus on population-specific issues? I'm now on slide 19, and here I'm going to talk about really quickly the pathway. So how do we get from ideologies, the big things I talked about, white supremacy, settler colonialism, and structural racism, to then unequal, inequitable social and health outcomes? So I'm starting from the left-hand side and moving my way down. So you can think about these big things as colonial and racist ideologies. So these are really the systems which form our worldview. And our worldview it's almost like, the ocean, the water within which we swim. So it's how we think about the world, our values, our norms, how we think society should be organized. So through this, we have stereotypes which are based on race, and I named a couple of them earlier. And these stereotypes or beliefs are often negative, they're often exaggerated, and they're directed towards specific groups of people. And given that we are all individuals, we are all carrying those beliefs with us. And so decision makers can then use those ideas to embed and reinforce unequal power relations. So we make decisions based on that. So an example, in an educational setting, if you think Indigenous kids have lower IQs, the likelihood that we're going to put in policies to then support them to achieve their fullest potential are less, because we just believe that they cannot achieve. Obviously, not true, but those beliefs do exist and then influence our attitudes, so the ways in which we think about groups of people, they then influence our behaviors, so both individual, but then I think for me, more importantly, the institutional practices and the societal policies and norms. So in terms of behavior, I think it's important to point out that behavior can be, so racial discrimination can both be an action, so something which we do either explicitly or implicitly, or it can also be an inaction. So if we know that we have unequal or inequitable outcomes in particular communities and we fail to act to reduce them, that itself is a form of racial discrimination. And so all of these then work together to and lead to the impact we see at the very far right-hand side, which is inequitable social and health outcomes. in Ingrid's section of the presentation, she's going to delve more deeply into some of those inequitable social and health outcomes. So on slide 20, Ingrid is going to be talking a lot about state-sanctioned violence, but I thought it was important to highlight some other ways in which racism impacts health. So as I mentioned, through state-sanctioned violence, and by state-sanctioned, we're talking about policies which are put in place or allowed to stay in place by governments at different levels. Racism also affects health directly through racism-induced trauma, through social and economic deprivation, which we see in things like housing, education, employment, and in different sectors. Also increased exposure to toxic environments, both social, physical, and environmental, and a lot of Ingrid's work focuses on that. Also in the direct care, so in social and health systems, the kind of care people receive also affects health. There's a very direct impact on individuals through racially motivated violence, and also on the structural level, structural violence. We know that racism also has an effect on the physical body. So people talk about the weathering effects of racism, so how the body itself changes in response to racism. So slide 21 brings us to, if we know that racism is a problem, what do we do about it? I think anti-racism as a strategy helps us move forward and says that we can actually do something about racism, because if race and racism were created, then they can obviously be dismantled. Not easy, but not impossible. And so anti-racism is really action-oriented. It is a political strategy, and its focus is ultimately systemic and political change. Anti-racism also looks at how racism interacts with other systems of oppression. So really understanding that inequities are not a result of one single factor, but other things, other social systems are interacting with racism. And so I think good anti-racism, good decolonial work has to address all these things. Oftentimes I think when I see people developing strategies, education, which is what we're doing right now, is often a key part of it, but I strongly believe that education about racism in and of itself is not enough. So our anti-racism work has to ultimately lead to a change in what we do and how we do it, and which I think will lead to real changes in the life of Indigenous and racialized people. So I'm going to end really with some of my tips, and these for me are based on the kinds of responses I get when I talk about racism in the Canadian context. So typically when I talk about racism and settler colonialism, I get a response about diversity and multiculturalism. Multiculturalism is official Canadian policy. I think it's a beautiful thing. It's this idea of embracing people from different cultures and building a diverse Canada. Everything we know says that as an approach, that itself has not been successful in reducing racism. So I think being able to name and frame racism and settler colonialism as the problem is really important. My second tip is stay focused on settler colonialism and racism while thinking about intersectionality. So another thing which typically happens is you're in your office, in your workplace, you raise racism as a problem, and someone says, yeah, but what about women? Not what about racialized women, what about women generally, or what about people who are living with disabilities? Again, very important things to pay attention to, but there's a tendency to shy away from racism very quickly. So I think if you want to do work on racism, it's really important to keep that focus. If you say, what about women? I think it's beautiful. Let's think about racialized women, Indigenous women in that conversation, and not just sidestep it. Also important is to center the leadership of Indigenous and racialized peoples who are bearing the brunt of racism on a daily basis, who have expertise in this area, both lived and acquired through their own knowledge and expertise. Fourthly is broaden how we think about racism. I think we chose expressly to think about racism as structural for today's conversation, because it tends to be, we tend to reduce racism to the most individual forms. Think about the news, right? When we hear racism on the news, it's typically something highly individualized and not as much on racism as a system, racism in policy. So I think that's a really important bit. My fifth tip is focusing on the impact and not on the intent. So I think one of the distraction to the conversation is, I did not mean it, or we as an organization did not mean it. But I think if you focus on the impact, if racism is raised as a concern in your organization or in your work, then I think that's an important thing to listen to. Okay, so what is actually happening? What kind of inequitable impact are we seeing here? Not did I mean it or not. And also I think it's important to address all forms of racism, so internalized, so how we embody racism within ourselves, the interpersonal between people, and also the institutional. And on a daily basis being attentive to how the everyday racism functions as well as the systems. But ultimately, I believe that racism, if the problem is a systemic and a structural problem, our interventions then have to be at that level for them to actually be meaningful and successful. I think there have been some very positive developments lately. I wanted to flag, for those of you who are not in Ontario, Ontario now has an anti-racism strategic plan or strategic action plan, which is a, I think, 3 or 5 year plan focused on the province. I think at a governmental level, that's a pretty important piece of work which is happening. And we'll share the link in the chat box if people want to take a look at that later on. So I think that's a great example of a systems level intervention. I also wanted to flag the Truth and Reconciliation Commission report. 94 calls to action. I think there's an action in there for every individual and every organization, so important document to read and act on in whatever small way you can. So that is our little intro, exploring core concepts. I'm going to now pass it on to Ingrid. We're now on slide 24, and Ingrid is going to talk about some of the impacts on racism, sharing from her work, and also share some of her ideas about strategies we can start to implement in our everyday work. Ingrid, off to you.
Great, thanks, Sume. So what I want to do, the main objective of this presentation is to discuss the health and mental health impacts of racism, and I'm going to use the term state-sanctioned racial violence and explain what that means, as well as outline how racism can be addressed by health professionals and the health system. Let me just change the slide. So in terms of the objective, there are many objectives. I first want to define state-sanctioned racial violence. It's a term that's being used more often today, so I think it's something that should be in our lexicon as health professionals and mental health professionals. We need to be acquainted with this term. So I want to define state-sanctioned racial violence and its health and mental health impacts, choosing particular communities, the Black Canadian community, including African Nova Scotian communities, Indigenous communities, and immigrant communities. I also want to discuss some of the limitations of cultural competence. That's a term and something that we do or we're trained to do as health and mental health professionals, but I want to talk about some of the limitations of a cultural competency approach. So it's not about getting rid of that approach or that understanding, but trying to move beyond a cultural competency approach. And then I also want to provide some suggestions for how health professionals and the healthcare system particularly can begin to engage in discussions on racism and address its health and mental health impacts. So first, I believe that it's important to define state-sanctioned racial violence, because often when we say racism, we don't really talk about the source of that racism. We just say racism, and we're not really quite sure where it's coming from. So I think the term state-sanctioned racial violence is a good term because it suggests or it indicates that racism comes from the state through policies and decision-making that happen at the state level and within various institutions. So it's through those policies, through that decision-making, through those actions that racism is meted out to particular groups in very different ways in society and impacts their health. So state-sanctioned violence or state-sanctioned racial violence, which is what we're going to talk about today, I think is a really ideal term to get at that source of racism, that it's coming from someplace. So it refers then to some of the systemic and systematic ways in which government and various social institutions harm or disadvantage the communities I mentioned earlier, Indigenous communities and racialized communities, preventing them from meeting their basic needs. And when I talk about basic needs and their rights, I'm talking about their basic needs and rights related to employment, to justice, to housing, to food security, and other resources, all the things that we tend to take for granted, but that some communities find it difficult to access at the same level or at the same rate as a dominant white population. So like structural racism or institutional racism, what we're talking about when we talk about state-sanctioned racial violence is racial violence that's very subtle, it's invisible, and it certainly has no one specific person who can or will be held responsible for it because it happens institutionally, right? So these are some of the terms, as I mentioned earlier, that we often use. Structural violence is increasingly becoming popular. Institutional racism, institutional inequalities, and structural racism. So these terms are interchangeable perhaps to a certain level. You can define it in the same way that you define state-sanctioned violence, but I think state-sanctioned violence actually tells you where it's coming from. So this is a full breadth or examples of state-sanctioned racial violence that Indigenous and racialized communities are experiencing today in Canada. Gentrification, which is something that you may not think of as structural violence or state-sanctioned violence, but is, because it encompasses a lot of different things related to housing and jobs and green space and infrastructure and neighborhoods and all the determinants of health that we talk about. So poor quality housing as well, unemployment and underemployment, income insecurity and poverty, criminalization, over-policing, police brutality, and disproportionate rates of incarceration in non-white communities, and also environmental racism, the disproportionate location of industries, harmful industries in Indigenous communities and other communities. So I just want to get a little bit more into state-sanctioned racial violence in terms of some of the statistics. So when we're talking about state-sanctioned racial violence and its impact on health and mental health, we need to know what we're talking about, right? So somebody might say to you, well, what does that mean and what's the proof? The proof is in the pudding, the proof is in the statistics. So we have here statistics for employment, specifically for African Nova Scotians, but you're going to find that the story is very similar in the rest of Canada and certainly in the United States, where we find that racialized communities tend to fare worse with respect to all of these social indicators. So this is the most recent statistics we have in Nova Scotia in terms of employment. And I don't want to give you all of the details because it will take too long, but we know that African Nova Scotians have a rate of unemployment higher than the rest of Nova Scotia and African Canadians across Canada except for Indigenous peoples. African Nova Scotians have a higher rate then of low income than the rest of Nova Scotia except for Indigenous people. They have lower rates of educational achievement, particularly they are less likely to finish high school or attend university. And recently the Provincial Department of Justice collected statistics and found that African Nova Scotian people were overrepresented in the province's jail system. Rates are very similar to Mi'kmaq or Indigenous peoples in Nova Scotia. And we also know that they suffer higher rates of street checks. In Toronto, there's an issue around carding right now. And in Nova Scotia, there's much outrage about street checks. So we call that over-policing, right? So this notion that racialized people are criminalized in particular ways and then subjected to police brutality and other forms of over-policing. With respect to Indigenous people, the story is very similar, but in many cases they fare worse than African Nova Scotians. Criminal justice system Similarly, the Provincial Department of Justice shows that between 2014 and 2015, the Mi'kmaq people in Nova Scotia were also overrepresented in the province's jail system. With respect to the labor force, only 50% of people living on reserve participate in the labor force compared to 63% for the total Mi'kmaq population, the same rate as the general population. And then when we look at the issue of gender, so as Sume mentioned earlier, we have to engage with an intersectional analysis that looks at issues of race as it intersects with gender and class and disability and age and citizenship. So when we look at the situation of Indigenous women in Canada, we also know that they experience high rates of unemployment, low income, poverty, and violence in the form of sexual, physical, and emotional abuse, as well as through the epidemic of missing and murdered girls and women. Right, that's very much a sociological issue. The sociology around why Indigenous women tend to disappear is something that we are grappling with now in Canada. That's certainly a determinant of health because it's about violence, but it also relates to a host of other issues, as I said, like income and poverty, and of course gender violence. And other forms of state-sanctioned violence that Indigenous people are experiencing, of course, is the lack of full community governance and self-determination, substandard housing, and overcrowding on reserves, and the whole gamut of issues under colonialism, right? As Sume mentioned, we are all living in a white settler society, and what comes with that is a whole host of issues facing Indigenous peoples who are trying to access various sources, whether it be housing or food or health services or jobs, all a result of colonialism. So the specific forms of racism that Indigenous people face is very unique to their history, as is for the African Nova Scotian community, the African Canadian community. So let's get to the migrant population. And I'm sure all of you as health professionals have heard of the term the healthy immigrant effect. So that really encapsulates well some of the social determinants or the forms of state-sanctioned racial violence that is meted out specifically to migrant individuals. So we know that the health of immigrant and refugee populations are impacted by specific forms of state-sanctioned violence. So in general, we can say that many of these issues you will also find in the African Canadian community, in the Indigenous community. But when we look at specific communities, we have to look at how the experience is very unique for them based on their social circumstance. So we know that when, for example, migrants come to Canada, we all know that in general they tend to be much more highly educated than the Canadian population. However, they jump through a considerable amount of hoops in terms of getting accredited for their degrees and job skills. So we've heard the stories, which are very much true, that they may come to Canada as doctors, as medical doctors, and are driving taxis. And while that seems, it seems far-fetched, it's very much true. I think if you drive in as many taxis as I do, and you start to talk to taxi drivers, you will find out that they're very highly educated. So that's going to have an impact on your health, certainly. So getting accredited for your degrees and your experience, the experience and degrees you got back home, and when you come to Canada, those degrees and skills are not recognized. That's certainly a form of state-sanctioned violence coming from a system in Canada that doesn't give credence to people's educational background for a host of reasons. Number two, of course, difficulties finding employment, because if you're finding difficulties getting accredited, then it's very difficult to find employment. It's difficult to find employment in general as a migrant, but it's certainly very difficult to find employment that is reflective of your educational background and your skills. And certainly unemployment and underemployment, working several jobs for years, jumping through hoops, taking multiple tests, in order to get accredited. All those things are issues that particularly the new immigrant faces. Income insecurity and poverty, and exploitation by employers, something that is often not talked about, but when you're a migrant and let's say you're working in Canada perhaps under the table, your employer might know that you have this fear of being sent back home, as it were, right? So knowing that you have this fear can lead some employers to exploit you with respect to work conditions, overtime, and certainly if you're in a non-unionized job, then you're more vulnerable to exploitation. So when we look at the issue of jobs, for instance, or the issue of employment, we need to look at the full gamut of employment, not just whether or not somebody is able to find a job, but what's actually happening in your workplace. And for a lot of migrants, they're very, very vulnerable to exploitation by employers. And a lot of migrants also, when they first come to Canada, tend to reside in under-resourced neighborhoods. So that's another issue. When we look at the social determinants of health, we know that neighborhood and urban space is a significant determinant of health. Where you live is a significant determinant of health. If where you live doesn't have a lot of green space or employment opportunities or a recreation center or a place where your children can play or good roads, then that's considered to be a neighborhood that's not always of high quality because the infrastructure is vulnerable. The infrastructure is poor. And those are issues that are key to well-being. So typically, not all the time, but migrants tend to, when they first come to Canada, move into under-resourced neighborhoods, and then oftentimes they move out of those neighborhoods. But when we look at the 5 years after which an immigrant or a migrant or a newcomer comes to Canada, these are typically the areas that they are living in as they are trying to survive. So what are some of the health and mental health outcomes of state-sanctioned violence? These are health and mental health issues that are indicated in the literature, and they are health and mental health issues that pertain to Black Canadians, Indigenous populations, and migrants, and some at higher levels than others for specific communities. So all of these here, I don't necessarily have to read it out, but with certainly high stress when you're living with experiences of state-sanctioned racial violence or structural racism. We know that there's a connection now between stress and racism. This is something that was discounted a while ago, and now there's evidence coming out, particularly in the States, because in the United States, they do collect statistics on race and health. We are seeing that there's certainly a connection between stress and health and mental health. We know this because we know that when we're under stress, all of us, our cortisol level rises. And when our cortisol level rises, then that disposes us to a host of various illnesses, including cancer and mental health issues. For racialized communities and Indigenous communities, this is a particular problem because they tend to be under threat at higher rates than other populations for the reasons I mentioned earlier. And of course, associated with stress is anxiety, high blood pressure. We've often heard that African Canadians, Caribbean people in the Caribbean have higher rates of blood pressure than other communities. And some have said that it has to do with our genetic makeup. That's being discounted these days. Many more people are more likely to say that it has to do with high levels of stress. And certainly if you are a migrant in Canada, then it's the issue around racism and other stressors that you're facing. Stroke as well, clinical depression is an obvious outcome of the stress that you face and the discrimination that you face as an Indigenous person, as a Black person, as other racialized people. We know that in Canada, Indigenous people have the highest rates of suicide, and we're hearing those stories. We've been hearing those stories for a while. High suicide rates in Indigenous communities and young people taking their lives, right? Happening typically on reserves, a kind of isolated community, a place of home for Indigenous people. So reserves are interesting because you feel a sense of home and you feel a sense of comfort being amongst people from your community, but at the same time, you're in a situation where there isn't a lot to do, and there are the intergenerational effects of poverty and colonialism, and also being in an environment where there's high levels of substance dependence. So you tend to fall into that trap as well as a young person or an adult on a reserve. So clinical depression and suicidal ideation and committing suicide, we know that there are high rates in Indigenous communities. We don't know for the other communities because, once again, we need to collect statistics on race and health. What's coming out in the United States is that Black populations, the rates of suicide is increasing. And something that's not really talked about in the United States is the high rate of suicide among Black men. We're so focused on Black men and so-called Black-on-Black crime that I think we've missed this new statistics coming out in the United States that Black men are increasingly committing suicide. High rates of obesity. One thing we know these days is that obesity is not simply about behavior, right? So there are studies coming out that link poverty with obesity. So obesity is not just about you need to stop eating. I think as health professionals, we perhaps know that now. Obesity is now being linked with poverty. So what you're going to find is people who live in poor communities, who have less access to healthy food, and who, as a result, are forced to buy food with high salt and fat and sugar content because it's cheaper, then they're certainly going to be more susceptible to obesity. So obesity, we should conceptualize it as an issue of poverty. And certainly diabetes as well is certainly high in Indigenous communities and Black communities, and heart disease. You're noticing that all of these illnesses that are listed are very much connected to stress. If you look at some of these illnesses, they're connected to stress. And racism is a stressor. Once again, we don't talk about it that way in Canada. We have ways to go in terms of conceptualizing racism as a stressor, but race-based stress is certainly real. Skin and respiratory diseases, part of that would have to do with the fact that Indigenous and Black communities, but primarily Indigenous communities, tend to live close to environmental hazards. So when we talk about respiratory diseases or even asthma, we have to think about where these communities are located. And if they're located closer to polluting industries and other environmental contaminants and pollutants, then they will have higher rates of asthma and other respiratory diseases. Death by suicide and family violence, high rates in Indigenous communities and certainly Black communities as well. We know that violence, physical violence, is often an outcome of depression and the inability to cope. So we also have to reconceptualize this issue of violence. When we think of family violence, it's about the family dynamic perhaps. It's about what's happening out there structurally and how people are able or not able to cope with some of the structural issues that they are facing. Decreased life expectancies high in the Indigenous community, increased infant mortality high in the Indigenous community, and then prostate, aggressive breast cancer, and other forms of cancer are high in both the Black and Indigenous community. In the African Nova Scotian community, Black men are now looking at rates of prostate cancer. While, once again, we don't collect statistics on health and race, there is a belief in Nova Scotia that this is an issue for Black men, and there are various support groups that have been popping up to look at Black men's health, specifically in Nova Scotia, and prostate cancer is something that they recognize as a particular problem in the Black male community in Nova Scotia and perhaps in Canada as well. What's interesting with respect to cancer is that the cancer rates among, for example, Black women in the United States may be lower than for white women, but when a Black woman gets cancer, it's more aggressive. And the explanation for that is that Black women are less likely to see their health care provider. So while, once again, the rate, and that was a few years ago, so I don't know what it is now, but the rate might be lower. The rate of cancer might be lower for Black women versus white women. When Black women do get cancer, their cancer is much more aggressive. So once again, this has to do with the fact that it takes them longer to see a healthcare professional. So by the time that they do see that healthcare professional, it's often too late, right? They're at an advanced stage of cancer. So we have to look at what's happening and what's not happening within health care that would inhibit or create a barrier for non-white women to seek out health care. And then I talked about asthma. So those are some of the health and mental health issues facing these communities, and we know if we kind of abide by a holistic understanding of health, we know that health and mental health are connected, right? So as health professionals, we have to kind of abandon this notion that these are two separate things. Your health affects your mental health, and your mental health affects your health. Sometimes we use the term psychosomatic disease or psychosomatic disorder to kind of embrace a more holistic understanding of health. But you'll see that all of those health issues are very much connected. So I want to talk about the need to move beyond cultural competency, because this is a language we use as health professionals. But before I do that, I want to kind of define cultural competency, and I'm sure most of you or all of you have an understanding of this. So what is cultural competency? It's about self-examination, an in-depth exploration of one's own beliefs and values. In other words, if you are going to be addressing the healthcare needs of culturally and racially diverse individuals, you have to engage in a kind of self-examination about your own values and your own beliefs in order for you to help somebody else, because they're going to be coming to you with their own beliefs and their own values from their culture. So you can't embrace them until you go deeper inside yourself to kind of get a sense of your biases and your worldviews and how those things will prevent you from providing adequate care to people who have different beliefs than you do. It's also learning about your patient's culture and worldview. So none of these things I'm saying are bad things, right? So I don't want to get that across here. These are all good things that you should be doing, learning about your patient's culture and worldview. You can't do that for every single client because you have a lot of clients who come to you from different parts of the world. So it's impossible for you to know about everybody's culture, but you do your best as a health professional to gain the knowledge that you need to understand somebody's worldview. You also want to recognize differences in communication styles and etiquette between different cultures, right? So even in terms of where you stand and gestures and expressions and facial expressions and whether or not you should stand too close to somebody or whether or not certain cultures like a little bit more space, which is actually a real issue, right? There are certain cultures that like to be close and other cultures that want space. All of those kind of non-verbal cues is also helpful for professionals to understand. So taking that into consideration in terms of eye contact, facial expressions, etc., using appropriate language and literacy levels, going beyond the kind of one-to-one relationship. It's also about, as health professionals, you're designing programs and policies. You want to make sure that you have translators, that you have cultural brokers, that you have interpreters, that your programs and services are culturally reflective. All of these things are cultural competence approaches that you may have instituted in your programs and services or in your policies. And of course, performing cultural assessments as a service. How do we ensure that our health professionals are performing cultural assessments that consider other people's beliefs and values? So all of those things are great. And these are some of the strategies that as health professionals we've learned over the years. We think this is a good thing to do, and it is. But it's also important to move beyond that because a focus on cultural competency often is a focus on the individual. And it's a focus on culture, which essentializes people's culture and can often lead to stereotyping. But it's also not the answer to some of the structural issues, the forms of state-sanctioned violence that some of these communities are bringing to a health service or to a program, right? So when they come to a service or program, they're coming, and what comes with them is all of the experiences that may have nothing to do with their cultural views and their worldviews, but with the forms of state-sanctioned violence that I talked about earlier that they don't know what to do with. And as health professionals, we need to begin to to address some of those structural issues. So for me, cultural competence is almost like a Band-Aid. It's surface level. It can only go so far. Structural competency to me is a little bit more effective because you're getting at some of those systemic issues. So I would like to suggest then that as health professionals, we move beyond a cultural competency approach to interventions that require us to address the processes, the decisions, and policies at the state and institutional levels, because those are the factors that create health disparities. So instead of us internalizing health disparities within the client by saying that it's the client's difference, it's the fact that the client is different, it's the fact that the client comes from a different culture, that's creating the problem, and that's internalization. We should be looking at the systems and processes and decisions at the government level and at the institutional level that create those health disparities. So what we then need to do as health professionals is to look at some of those issues and act on it, right? Interacting with your client in a patient and sensitive way isn't going to get you very far. But acting on and addressing the underlying systemic and structural issues, the forms of state-sanctioned racial violence I mentioned earlier, which are the real causes of health disparities, are what we need to start to do. So when I talked earlier about underachievement in the educational system, criminalization, unemployment, food security issues, poverty, income insecurity, poor infrastructure in neighborhoods, those are the underlying structural issues that lead to health disparities. Those are the social determinants of health. So we're not abandoning cultural competency. What we're doing is we're understanding how culture intersects with structure, right? How somebody's culture and somebody's difference actually intersects with structure, because it's the structures that actually take those differences and mete out disadvantages to individuals based on those differences. So what are some of the strategies that we can do to address the structural issues in healthcare? Education first is the most important issue. Some people say, I don't know what to do, I don't know how to start the conversation. It's very simple. It has to start within your organization, whether it's a workshop, whether it's something, a standing workshop every single month. You need to start bringing education into your program or service. But that education, to me, must incorporate a structural competency approach. So if you continue with the cultural competency approach, I don't think you're going to get very far. That's the beginning. That needs to move beyond that to a structural competency lens where you're talking about education, right? So instead of seeing education as having nothing to do with health, education is every bit about health. Instead of seeing policing and over-incarceration as having nothing to do with health, we have to start talking about criminalization and police brutality as a health issue. We need to be talking about jobs as a health issue. So if we're going to start to educate and train and engage in workshops in your workplace, we have to talk about the so-called non-health issues in order to start a conversation about health disparities. This needs to start at universities with a social determinants course. It needs to start at universities, but it also needs to start within your organizations and with healthcare providers. I think what needs to happen is we need to correct the ways in which we train people. And right now in Canada, and to a certain extent in the United States, we are still working with that surface level cultural competency, this person is different from me approach. And we're not talking about education or policing or police brutality or employment or all the other structural issues that are meted out by the state that are the underlying causes of health disparities. So changing our ideology and conceptualizations of health is important. So that's education. We also need to start centering race in all of our interactions. So what we tend to do as health professionals is we tend to medicalize the issue of race. We tend to medicalize the issue of trauma, and we see these things as scientific. We need to move away a bit from scientific language to language that interrogates the medicalization, the tendency to medicalize trauma, and to look at some of the social issues, as I talked about earlier, as the underlying causes of health problems and how we diagnose people. Since not every illness has a scientific explanation, then it's incumbent upon us to interrogate those structural factors that create illness and health issues. Also important is creating a diverse workforce. To a large extent, we're not doing that in Canada. Typical responses, I don't know where to find educated people who are Indigenous and Black Canadians who have the skills and competence to work in our healthcare field. And I would say that people aren't trying hard enough. There are various initiatives. For example, in Nova Scotia, we have diversity bursary awards from the Nova Scotia Health Authority that encourages Black and Indigenous students to pursue health education, to become health professionals. There are various things that you can do within your organizations to reach out to young people, to reach out to health professionals in other areas, to bring them into your program or your workplace. So we need to start creating a diverse workforce, a healthcare workforce that is representative of the diverse society it serves. It's very hard to connect with marginalized or diverse communities if they don't see themselves represented in the healthcare field. And if the health professional doesn't look like them, often they're not able to relate. And that's one of the main reasons why individuals from racially diverse backgrounds don't access healthcare, because they don't see somebody like themselves. So in order to encourage people to access health services, you need to have a workforce that is diverse and representative, not just in terms of skin color, but in terms of people's belief systems as well. So I won't go into all the benefits of having a diverse workforce. But as I said, in general, people need to see people who look like them. They're more likely to engage. I also think what needs to happen is for different departments or services to forge interdepartmental collaborations. So what I find is not happening, for example, in government in Nova Scotia is crosstalk, right? So the people in health stay in their bubble, and the people in justice stay in their bubble, and the people in immigration stay in their bubble, and the people in education stay in their bubble. Now, all of those things I just mentioned are determinants of health, right? So why aren't they engaging in more crosstalk? If justice and education and jobs are some of the structural factors that impact health, why aren't people in health talking to people in justice? So some of the things I've noticed is that we've been talking about the determinants of health for years. We've been talking about cultural competency for years, and nothing has changed. And I asked somebody that. I said, have you wondered why nothing has changed? And the person said, yeah. And I said, is it because we're not engaging in crosstalk? Right? So I think what needs to happen more in terms of addressing the determinants of health or structural issues is that you need to start talking to people in other departments and other areas and community organizations, because those are the people who are dealing with some of the underlying causes of health disparities. We also need to forge partnerships between healthcare professionals and the racialized communities. Often you're working in a bubble. You try to figure out how to deal with all these issues, but you're not even talking to community-based agencies. You're not talking to racialized communities. And sometimes you might say that it's very hard to find racialized communities to speak with. But the avenue through which you find those individuals are through the community-based organizations that they frequent, right? So the first step in terms of kind of figuring out what should I include in this policy that reflects the diverse community. I don't know how to engage in a discussion on race. Well, the first place to start is with those community-based agencies that are connected to racially diverse communities, and we all have them in our city. People who are working, they're not in health, they're not health agencies, they're immigrant integration agencies, they're community-based agencies, they're social services, they're legal aid services, but those are the determinants of health, right? So, and those people are, those agencies are connected to the communities that you should want to hear from, because when you set about developing your policies and your programs, you want you want those programs and policies to be reflective of the community, but you don't know where to find the community, but they're right there in your backyard. So forging authentic relationships with community-based agencies, I think, is also a first step. Also, legislation. Sometimes as healthcare professionals, we feel that our job is just to be a healthcare professional, when our job is actually everything else as well. One of the things I teach my nursing students is that your job isn't just to be a nursing student, but it's a nursing student or to be a nurse, but it's also to advocate for your clients. And you may be doing things that seem to be outside of your field or outside of your job duties. And I say to my students, actually it's all part of your work, advocating for your clients. And advocating could include developing legislation. So when I talk about advocating and community capacity building, for example, for a person in policy or in a healthcare organization, I'm talking about helping clients and community members with their social needs, with their legal issues, with issues around food and food security, connecting them to various community-based organizations so they can deal with some of those social issues that actually underlie some of their health problems. So as a health professional, it goes beyond developing a policy or sitting behind a desk. It's also about interacting with the community and advocating on their behalf. And in many ways, this could include legislation, right? So as a health professional, we want to see you on committees and boards. We want to see you working with governments to develop legislation. But that legislation might be a legislation on poverty. But guess what? Poverty is a determinant of health. So I consider a legislation on poverty a health legislation. So we have to kind of open up our parameters in terms of what we consider health. So if you hear about a poverty bill that's going forward, you might say, well, that's not health. So that's outside of my knowledge, but poverty is a health issue, and justice is a health issue, and gender violence is a health issue, and environmental racism, which I look at, is a health issue. All these things are health issues. So if you address the issue of poverty, you are addressing health. So once again, opening up our parameters about health. So that's all I have. I think I've gone over time, and I'll just send it back to Sume.
Great. Thank you very much, Ingrid. I think that was a very engaging presentation. We do have about 20 minutes for questions and a bit more for conversation, and I can see that there are questions coming in. So what we're going to do now is we're just going to start taking the questions in the order in which they came in. If we're not able to get through all the questions on the call today, we'll do our best to follow up after the presentation. And so I'll encourage you all to keep sending the questions. And I see that there's some interesting discussion going on in there, which we will try and get to. So just to get us started, there's a question from Lauren Henderson, which is, are there national health surveys in Canada that include discrimination scales?
Are there national
health surveys in Canada that include discrimination scales? The CCHS Canadian Community Health Survey in 2014, I believe they did a rapid response module focusing on on everyday discrimination. It was an adaptation of the everyday discrimination scale, which has been developed and tested extensively in the U.S. It was done as a one-off thing, but there is currently a conversation being led by CIHI and Stats Canada and a few other organizations on race and ethnicity data for health inequity data in the healthcare system. So that work is happening. It doesn't happen regularly. At the local level, I know in Toronto, some of the local health integration networks, specifically the Toronto Central Health LIN, requires that organizations now collect race-based data. And they have a document which includes the kinds of questions they ask and how they ask them, which we can share with you. And there are probably a few others. The Primary Care Access Survey is another one where they do ask some questions related to, well, it's a mishmash of race and ethnicity, which tends to happen in surveys and when we ask questions. So that will be another source. Ingrid, are you aware of any others? Anyone on the call aware of any others?
I'm not.
If you know other examples, drop them in the chat box. Yeah, thanks for sharing that link, Hannah. All right. So there is another question. So this question is this question is from Andrew Gray, and Ingrid, this is for you. It's in reference to your comments about the fact that Black women in the States tend to be diagnosed with lower rates of cancer. So the question is, but then in the treatment, so diagnosed with lower rates, but then the cancer tends to be more severe. And the question is, could that be driven by an overdiagnosis among white women, which then inflates the rates of cancer in that population?
I think in the term, well, the articles that I've read, now that's a few years back, there was no indication that it was an overdiagnosis in white women. I think the focus really was on Black women and what they were doing or not doing. So I haven't read that. That could be the case, but I think even if that were the case, I think those articles are speaking to the fact that Black women tend to not seek out health care. So not only with respect to cancer, but with other illnesses, they will fare worse because they're seeking out health care at a later stage or not at all. So the articles that I've read haven't talked about the overdiagnosis of white women with respect to cancer. They were more focused on the fact that Black women had more aggressive forms of cancer. Now, of course, that would depend on the type of cancer as well. This particular article was talking about breast cancer. And it was kind of engaging in an argument as to whether or not it was biologically induced, whether or not there was something about Black women's bodies that made them more vulnerable to aggressive forms of cancer. But at the end of the article was really about the fact that they wait to see their health professionals, and by that time, it's too late. So I think it speaks to a larger issue, which is that often racialized women don't seek out health care, even health care, and that it has really damaging effects, I guess, later on in terms of illnesses and mortality. And when I talked earlier about higher rates of mortality among Indigenous peoples in Canada, that would be part of it. So I think we also have to kind of move beyond this kind of scientific kind of biological blaming, that it's something inherent to the bodies of Indigenous women, for example, because that, of course, blames the person, and look at why they're not accessing health care, whether it's because they're living on reserve and they don't have access to health care, they don't have the means to travel to health care, they don't have the money to pay for travel, they've had a very bad experience and they don't want to go back. So all these things we have to explore. But overdiagnosis is something that I'm also interested in, because in terms of mental illness, we do know in the United States that there is overdiagnosis and underdiagnosis happening. So that's something that I've looked at in the past as well. So there's a wonderful book by Jonathan Metzl called The Protest Psychosis, How Schizophrenia Became a Black Disease. And we know that there's been a transformation of schizophrenia and the diagnosis of schizophrenia since the 1930s. And in this wonderful book by Jonathan Metzl, he talks about the overdiagnosis of schizophrenia among Black American men, the underdiagnosis of affective disorders like depression among Black women, and the overdiagnosis of depression among white women. So this is something I've looked at, but with respect to mental illness. So I'm not too clear on what's happening in terms of just health issues in general.
Great. Thanks, Ingrid. So we're going to keep going through the questions here. So the question coming in from Ashley Bray, how do you propose we create structural competency in an organization if culturally there is a lack of awareness about institutional inequalities?
That's where I think you bring in the partners, because if your workplace is homogenous racially and culturally, and you don't know where to start because you don't have the voices of the people that you're trying to target within your workplace, then that's where partnerships are needed, right? We have to take seriously the partnerships, and those partnerships are the community-based organizations, the immigrant integration services, legal aid, and other community-based services that are actually providing services to the communities that you're trying to target. So what we hear often is people say, I don't know where to start, we don't have the voices, I hear that often, my workplace is completely white, nobody knows what to do. And I say, well, it begins with partnerships. Have you forged authentic partnerships with the community-based agencies in your neighborhood? So in order to start to look at the structural issues, the immigrant integration agency down the street knows all about the structural issues facing the immigrant population because that's the population they're serving. So you want to bring them in. You want to bring them into your board. You want to bring them into your workshops and your education, and you want to work with them in order to start talking about these conversations, these issues. So I don't think you should feel that you have to do this alone, because in many instances these organizations would love to be part of it, but those partnerships aren't happening. I think when people start to actually engage in those partnerships, everything will open to them, and they will see how much easier it is to start the conversation because you're hearing from the people who are most affected. You're hearing from the organizations who are dealing directly with those populations that you're trying to serve, right? But these partnerships have to start in a very kind of organic and authentic way. You have to really want them as partners. You're not using them for information, but they're partners throughout the process. So in terms of structural competency, if I said that structural issues are education, policing, employment, neighborhoods, poverty, then the first step is to identify those community-based organizations that are not in health. They may have nothing to do with health. They're not health services, but those are the services you want. Identify who are the key players in your city. Start identifying the key people at those agencies you can reach out to, and start partnering and working with them in order to address, for example, justice and how that impacts health, and education and how that impacts health. That's the easiest way to start doing this work.
Thanks, Ingrid. So moving through our questions here, I think we probably have time for maybe two more. I'm going to skip through here. So there is a question about, this is a terminology question. It's from Dana Riley, and the question is, the term racialized is commonly used in the literature and by the speakers to mean non-white. We've heard from some researchers that this interpretation may be problematic because it ignores those that are privileged because of their reflected race, e.g. those seen as white. So they want to know what we think about that. So Ingrid, you're a sociologist, and I think in the social sciences, racialized is used very particular ways for very particular reasons. How about you get us started there?
Yeah, I'm a sociologist, and I use racialized. And I've used racialized in my reports, and then I had somebody who is Canadian but moved to the States where they tend to say people of color. He kind of corrected my report. He said, you got to change this to people of color. And I said, no, I'm good with racialized because that's what, it's a sociological term. And racialized for me, yes, it does exclude white people. So when we use the term racialized, we're not referring to white people, we're referring to non-white people. And it's this the process of being racialized can only refer to people of color or non-white people because white people are not racialized in the same way. That doesn't mean that white people are not a race because we know white is a race. And often white people don't see themselves as a race. They are. So I use the term racialized because for me it's a better term than visible minority, which focuses on color. And for me it's also a better term than people of color because that focuses on color. And for me, racialized focuses on power, right? So the process of being racialized is something that's initiated by a white person who racializes somebody who is different. And what goes along with that racialization process is various forms of state-sanctioned racial violence and structural violence. So for me, it's a good term. We know, I think visible minority is no longer considered to be a great term in Canada. That was a term we used in Canada throughout the 1990s, and everybody was fine with it, and now people have issues with the term visible minority. Some people will use people of color, but to me that doesn't speak to the issue of power, so I use racialized. I'm not sure what other people feel.
Yeah, I definitely agree. Like I do, and so this for me is also an audience question. In professional settings like this, I tend to use racialized. I do use people of color sometimes. In my everyday life, when I'm in my real life, I don't say racialized because then no one wants to talk to you. But I think it really for me, the language speaks to the process of how racist an idea is then taken up in society. So I find it a very useful term.
Mm-hmm.
Okay, so we're going to keep going here with the questions. Let's see here. So there's a question which is about, so it's speaking to this from Andrew Gray, and it's speaking to the focus on state-sanctioned racial violence. So Andrew says, I like the idea of naming the source of racial violence as the state, but I wonder whether it could be limited to focus on just the state and to attribute social inequalities primarily to the state. I see racism as a cultural phenomenon which is rooted in collective consciousness or unconsciousness of the dominant population. So what's the role of non-state actors in producing and reducing racism?
Yeah,
especially in the cultural realm.
Yeah, I think several things happen. Everyday forms of racial violence happen in interpersonal relationships between people. State-sanctioned violence is meted out by states and departments and agencies. But I think the culture within which we live and the racism in the culture within which we live is a product of the racism that's meted out by the state, right? So I think we live in a world where we're certainly interacting with people, and those interactions are highly raced, but they're legitimated by a state that meets out very subtle forms of racism in our society that's often taken for granted and that is often invisible. So while I think interpersonal interactions are very much racialized, I think our interactions are informed by the state. And the reason I say that is because we are socialized by the state and by various institutions to believe what we believe. So we're socialized by the media, that's state. We're socialized by the educational system, that's state. We're socialized by our workplace, that's state, right? So this is about the socialization process, and the culture within which we live is informed by our socialization within these various departments or organizations or institutions. So that's the state. At the same time, we kind of reify race in our interactions with other people, right? So race is never static. It's always under construction. So it's very dynamic. But I think when we think of socialization and how we come to know what we know and how we come to know about race and the way that we know it, we can point to our family, the media, to me, one of the most influential sources of racism, our educational system, our workplace, our interactions with other people, our healthcare system, etc. All of those things are embodiments of the state. So when we think of culture, we have to find that source. Because when we say it's in our culture, where did it come from? It comes from all of these institutions that reify race, that reconstruct race in very different ways over time, and that socialize us in particular ways. So when we interact with people, we're not interacting with them in isolation, but we're interacting with them in terms of how we were informed by media and education and jobs and family and your peers, right? So all of those things are happening together in tandem to inform how we think about race and how we treat people.
Great. Thank you, Ingrid. So let's see if we have time for one last question. Just going through here, if you have one which you haven't yet addressed. Oh yeah, so this will be our last question, and we'll follow up with the others. There are a few definitional questions in there. So the question is about, this is from Hannah Moffat from, she says, I'd suggest another way we could address racism in healthcare would be to improve our HR practices, which Ingrid, you mentioned. So have workplace policies to increase accountability when racism occurs? Like, do those policies exist? And what would some of those policies look like?
So what should the policies look like in the workplace to address racism?
That's correct.
Oh, well, when I think about some of the organizations that I know in Nova Scotia, and they're trying to grapple with overt and direct forms of racism in the workplace, as well as issues around hiring, what many of them are trying to do is to do monthly workshops to hear from your employees about some of the issues that are affecting them. So I think the only way to kind of put in place policies or programs to address racism, overt forms of racism or systemic issues, is to hear from staff. And the way to do that could be that you start with a survey. You start with a survey asking staff what needs to be addressed in the workplace, an anonymous survey, and then that's followed up by focus groups. I think in a way research needs to be done, not maybe hardcore research, but you need to hear from the people who are being affected, because many of them would not come to see anybody, or HR in particular, to express some of their views. So you need to have anonymous surveys asking staff that what they would like to see in the workplace, small focus groups asking staff some of the pressing issues around racism that has been affecting them, systemic ones around hiring or recruitment or retention, and also more overt ones. And then you need to have, not diversity training, I hate that word, but you need to have workshops and training that deal with systemic and overt forms of racism where staff feel comfortable. So every organization needs to look at itself, and it needs to figure out what it's doing and what it's not doing. And the only way to do that is to speak to staff. And you have to do that in a way where staff feels comfortable and secure that they're not going to be outed, they're not going to lose their jobs, and that means that you have to have a kind of anonymous system in place where you're getting people's views. So for me, it starts with a survey, which is statistical quantitative data. To me, it should be followed up by focus groups. And I also think that every workplace should have like a committee that's dealing with issues of racism or harassment, a small committee that meets every month to address this issue. And the survey should come from that committee, and the focus group should be facilitated by that committee. And you're looking at all these issues, you're collecting the data, you see what you find in the data, and then you deliver workshops on a monthly basis or bi-monthly basis or every 6 months to kind of find out where things are. So you need to start, you can't be afraid of what you're going to find, and you need to hear from staff. But you also need to, as I said before, you need to bring in outsiders, right? So you need to bring in those partners, those community-based agencies to help you develop that survey, right? To help, to guide you in terms of what should be included in that survey, to help you think about how you should address the issues when all the survey data and the focus group data comes in. How can you address the issue within your workplace? So to me, that's the kind of way it should unfold. Statistical survey, small focus groups where people feel safe, if that's something that's feasible. Once you collect the data, you analyze it, you see the gaps, you find out what's happening, and you put in place policies based on that data. And you have to start talking, people have to start talking, right? So you have to have workshops and education, and it has to be something that's sustained. A lot of organizations do that, and then they abandon it. They've had a workshop, and then there's not another workshop until 2 years or 3 years later because they're not really serious about it. The first step actually is really being serious. Do you really want to address racism? Do you truly want to address it? Because if you do, this will be something systemic within your organization, something that you don't abandon when it's no longer fun. So I think every agency has to ask itself, are you really serious about addressing it and creating a workplace that's safe and healthy for everybody?
Excellent. Thank you so much for that, Ingrid. We are at the end of our presentation. I'd like to thank Ingrid for joining us on the call today and sharing your tremendous expertise, and for all of you on the line for joining us. This is the first of a two-part webinar series, as I mentioned at the beginning, so please do visit our website for information about the second one. You will be receiving an email from us with an evaluation form, and I encourage you to please fill it out and let us know what else you'd like us to cover in this domain of racism and health. Thanks everyone for joining us, and take care.
Thank you.
Thanks, Ingrid.
Thank you.
Thanks, Danielle.